So this is the third session of the wrist injuries in sports. In this session, we will discuss about the different medical imaging, about the MRI, about the different views on the X-ray, which can be used for the assessing a different fracture as well as different ligaments tears. Okay. So during the sports, if there is any trauma, so the routine radiograph views, which include both the uh, simple PA and the PA view with the some radial deviation, they are used in the routine. But if there is any suspicion for the ligament injury, and then a PA view with the clean pist can be used. Similarly, a straight lateral view of the wrist with dorsum of the distal form and the hand forming a straight line, which permits the assessment of the distal radius, and not only the distal radius, but they also give a window for the discussion of that assessment of the lunate, the scapite, and the capitate as well. And these lateral view, they may give any idea about any instability which is difficult to identify and to recognize on the other views. So these stubborn instability that can be revealed under that straight lateral view related to the lunate, scapite, or the capitate. Um, Undisplaced distal radial or scapite fracture, however, they are very difficult to be absorbed and to be appear on the initial radiographs. And the clinical suspicion of fracture warrants investigation with other modalities, which include the different arthroscopy or the MRI or the CT scan or the bone scan. Um, During reading the PEG view of the wrist, some arc or some line that should be observed. Either they are present normally or they are disrupted. These specific lines, they are known as the Gilvina arcs or the Gilvina lines. These are the specific arcs which are present in the distal and the proximal row of the that carpal bones. Um, and if these lines should be smooth, and if these lines they are not smooth, then it means there is some a major abnormality is present. So we will discuss about in the upcoming slide that what we mean from the Gilula arcs. These are also known as the Gilula lines as well. So note the line joining the proximal ends of the proximal row of the corpus and the C shape of the metacarpal joint. And these lines, these are known as the Gilula arcs. If you look at these here, these are those PA view and the uh, Gilula views.
सर इससे किस टाइप का एमसीक्यू आएगा?
जी
सर इससे किस टाइप का एमसीक्यू आएगा? थोड़ा
अच्छा ओके सो गिलुला आर्क जो है ये हम इसलिए देखते हैं कि भाई इफ देयर इज एनी डिसलोकेशन और सबलक्सेशन ऑफ एनी कार्पल बोन्स एंड दे आर थ्री इन लाइंस यू कैन आल्सो नेम देम एज द गिलुला लाइंस दिस इज द 1 2 एंड 3 आपके सामने जो है ये नजर आ रहे हैं एंड व्हाई दे आर फॉर्म जस्ट बिकॉज दे आर राउंडेड इन शेप दे हैव वेरी स्मूथ corners, and that's why they give a very curve and arc. And if this arc they are not smooth, it means there is disruption. That simple mean there is some major abnormality in the carpal bones. So if we look at these three lines or three arcs, so this is the first one, and this is a smooth curve around the proximal convexities of the three bones, that is the scapite, and the triquetrum. On the other hand, if we look at the second line again, if we look at three bones, This is the triquetrum, that is the lunate and the scipite. So the second line, which is the of the gillular line, this is related to the concavity of that these three wounds. So a smooth curve around the distal. This is the proximal curve. This is the ulna. This is the distal radius, and this is the proximal boundary of the proximal row. This is the distal boundary, distal side of the proximal carpal row. So a smooth curve around the distal concave surface of the scipite, lunate, and the trapezium that make the second line of the gallula, or the second arc of the gallula arcs. The third gallula arc, or the third line of the gallula, this is a smooth curve that follows the proximal curvature of the capitate and hamat. It should be remember these two. This is the hamat, this is the capitate, and this is that proximal convexities of these two bones. If we look at here, this is that hamat and capitate, and this is that convexity. This is the concavity of the scipite triquetrum lunate, and this is the convexity and the proximal side of the proximal row. So these lines should be checked. If there any disruption, that will mean something is wrong here. Look at this picture. This is another X-ray, which is a disrupted one, an example of the disrupted arcs. Um, if we draw a line here, so again this line will not meet this line, which is the red one. So it means this is a disrupting. And if we draw another this yellow line, look at here, this is again disrupting and not meeting with each other. It means again this is something wrong with these. Either there may be some tearing or some spine to the intercarpal ligaments. There may be something wrong to that triangular fibrocartilage complex. There may be some fracture or some dislocation, subluxation of these small bones. Then what the problem there is? Again, it need the arthroscopy, it need that CT scan, if need that MRI, which I'll discuss in the upcoming slide. The proximal pole of the lunate fit into the concavity of the distal radius. This is the talking about that lateral view. If we look at here, this is that lateral view, and this is the one, two, three. So this is the concave, and this is the that convex side of that lunate. So the proximal pole of the lunate that fits into the concavity of the distal radius. This is that concavity of the distal radius, and the convex head of the capitate. This is the convex head of that. This is capitate. Fits into the distal concavity of lunate. So this is the lunate, which is in the proximal row. This is the distal row. This is the radius. So the convex of that lunate that's fit into the concavity of the distal radius, while the convexity of that capitate that is fits into the that concavity of the lunate. So on the lateral view, this mechanism, this element should be checked, and if there is no fitting of this convexity in these concavities, it means there is again disruption or some wrong to these bones. So if we are discussing another views as well in the upcoming slide, but these two are we have discussed the lateral view as well as the different Gilula's arcs in the PA. There is another problem with the ligament which is present between the scipite and the lunate. These are the two bones which are present in the proximal row. Uh, and sometimes when the ligaments or when there is some separation gapping between them, this is actually known as that the scapulolunate gap. And usually when there is gapping between the scipite and lunate, that give a ring sign, a shape of the ring on that PA view, and that is known as the signet sign, or also known as the ring sign. Sometimes it is also termed as in the literature as the cortical ring sign of the scapulolunate. And when this signet ring sign, or when this cortical ring sign is present, it indicates that there is the scapulolunate instability. What is, if we look it into detail, okay, I am admitting her. This cortical ring are that signet ring sign. This actually can be seen on the AP or the PA radiographs. So you can observe that not only on the PA but also on the AP. So it should be noted if it is in the MCQs that the signet ring sign that is present on the AP and the PA are both. So remember this the signet ring sign or another name which is the cortical ring sign. If that is present on both the PA or the AP view of the wrist, which this indicate that there is gap between the scapulohumerate and the diagnosis is the scapulohumerate instability. So actually, it referred to that dense or circular cortex of that scipite tubercle, which is made more prominent as the scipite assume a fixed position. So that fixed position, it means that is the specific view when the scipite that is in that flexion, and that will give that signal ring sign. Uh, we have discussed that later view as well. Another view which is known as the clinch fist view, or we can say that this is the variant of the PA view, the that posterior interior view. That simple means the patient or the person's he or she will just make a fist and then a PA view will be taken. If we look at here like this is the clinched fist PA view, and look at this is the x-ray of the that person which having this fist. This is the set of the x-ray, and the image which will be the result will be like that. So the clenched fist PA view should be taken if the scapular instability is suspected. uh, Scapular net stability that can also be assessed as we discussed on the that when there is a signet ring sign positive, but still if sometime this may be not as it is a very subtle indication that might be get unnoticed or ignored on the red scale. But still if the patient have that pain or that scipite problem and tenderness on that palpation, so the clench fist PA should be advised as well. This is indicated that now this is the most important, that when we will consider as instability, how many gap is allowed, and if the gap is more than that value, that will be considered as instability, and that value is the 3 mm. If that gap which we discussed in the previous slide, between the scipite and lunate, that scapulonate instability, if that widened gap is 3 millimeter, which means 0.1 inch, are greater than that between the scipite and lunate and the PA view, then this may be considered as uh, civilian net stability. But the problem is that sometimes even if the ligament which is present between the scaphoidolunate known as the scapholunate ligament, if it is still intact, so it is very difficult to absorb this scapholunate instability on the radiograph, and it take time when the that ligament between the scaphoid and lunate that is ruptured, this is teared, then that gap become more and that become easily visible on the radiograph. So until the tear of that scapulonate, it's very difficult to assess observe that scapulonate instability on the PA view. So this is another example of that clench view of the first clench view of the PA view of the wrist. This is one very important thing to remember in the which apparatus Paul, that the scapulohumerate instability which we discussed that cannot be ruled out on initial radiograph. Why? What is the reason? Because it may take some months for the scaphoid and lunate to separate significant radiographically. uh, Significantly radiography mean to be easily visible on the radiograph. It may take months after the instability. It means the instability will be present there, but still it will be not visible on the radiograph, and it may take months and months to have that widened gap between the scaphoid and lunate to be visible on the radiograph. The combination, there are some special views which can be used for different pathologies, specifically the carpal tunnel view or the that skipped views. So the combination of the complex anatomy of the wrist and the subtle wrist injuries and the small structures which are very complex and very difficult to differentiate from each other, um, that can cause substantial morbidity has led to the development of the specialized wrist imaging techniques just to identify and to have a precise and accurate diagnosis. We need some more specific views which make it easier for us to differentiate that what actually the problem is, what the correct diagnosis is. So there are some specific views like the special skipped views that should be requested, that should be advised if there is a suspicion of the fracture to the skipped bone. And how it can be suspicion, palpation of that the skipped area, there will be tenderness, so that may have a local tenderness, may patient may have some fracture at the that skipped. Uh, this is the different views which can be used for the skipped. This is this normal PA view, but these are the variants of that PA which is special the skipped series. This is the PA view with the ulnar deviation. This is the lateral, and this is the semi-pronated oblique position. Look at the position of the sand, and these all views they are used just to observe and just to check if there is any skipped fracture. Um, Sometimes the patient may have some disrupted tunnel or a row, so the best view for that is known as the carpal tunnel view, with the wrist and dorsiflexion allow inspection of the hook of the hamate and the ridge of the trapezium. So if we look at this, these are the different position. Both position are correct. If we look at this one, in which there is 30 degrees should be between the hand and between the palmar side and the cassette, this is also correct. And as well as this position, this is that case at the direction of the x-ray will be in that direction. So both are the correct position and both are termed as the carpal tunnel view. um, the x-ray after this position, that will be like that. These are the those fingers, these are the different bones, and this one, this is that will be the image after this one. So these both are specifically known as the carpal tunnel views, which is necessary for the checking the integrity and for checking that normal alignment of these carpal bones. If there is a suspected mechanical pathology like the occult ganglion, like the fracture, the non-linear or bone necrosis, these ganglion and fracture, all these they will be discussed later when we will discuss the subacute and chronic cases or the other causes of the acute wrist pain. Several other modalities that can be useful, like the ultrasonography, the radionuclide bone scan, the CT scan, or the MRI. um, Among them, the MRI and the bone scan, they are very useful. They are very commonly used because of their higher sensitivity and specificity. The ultrasonography, that is a quick and accessible way to assess soft tissue abnormalities such as the tendon injury, synovial thickening, and the ganglions and the synovial cyst. But the CT scan, that the main disadvantage of the CT scan is that it can be mostly used only for the fracture identification, and for those fracture which are unable to view, which are unable to identifiable on the normal radiograph. So then CT scan can be used for such fractures. But MRI and the ultrasonography, these two modalities, they can be very useful to check any bony problem, bony pathologies, along with some abnormalities and some problems with the soft tissue like the tendons, ligaments, these thickening of the different synovial sheath, the ganglion, cyst, and any type that tendinopathy or sprain or strain, then the MRI or the ultrasonography, and specifically the MRI can help in such condition. The important thing, the disadvantage about ultrasonography is that it is dependent on that expert, the interpretation that is subject to, and not objective like the other one. So it's very difficult to clearly answer that if there is the whether the condition is present or not. So then the MRI is considered as a gold standard for the assessing the MSK condition in the human body. Bone scan, they have very high sensitivity, but on the other hand, these may have some low specificity, and that is the reason these bone scans, because of high sensitivity, they can be effectively used in the rule out of the subtle fractures. Because we have a formula which is known as the snout, which mean that the high sensitivity test, when it is negative, then the condition will be ruled out. Similarly, the MRI may be equally sensitive and more specific than a bone scan. So that means the MRI is more accurate and more precise than the bone scan, because both have high sensitivity, but as compared to the bone scan, MRI has also higher specificity as well. So that's why MRI is much superior to the bone scan. And why it is superior to the CT scan? Because MRI can observe and can just check for the soft tissue structures, as the CT scan can't. So the CT scan is particularly that can be used for the soft tissue, but not that clearly and most commonly routinely used as MRI is. So the CT scan, that is particularly useful for evaluating the fracture. They are difficult to evaluate fully on that plan film, but MRI can also provide information about the soft tissue. That's why it is the superior. So thus a complete scapulohumerate ligament tear is more effectively identified with MRI than CT. So MRI will be the best option, and that will be the more accurate modality for the identification of this tear. So these are some of the MR images which giving some different ligamentous tear. This is that scipite, this is the lunate, this is the triquetrum. So this is that ligament which is present, which is necessary to maintain the stability of these two bones. Similarly, this is another image which give that positive indication for that scapulolunate tear. This is another MR which give the that triangular fibrocartilage tear. Arthrography, that is not used because of low sensitivity and specificity, but as compared to arthrography, the arthroscopy, that is excellent because it have good sensitivity and specificity. So it is excellent for the detecting the early scapulohumerate ligament tear in patients. Also, it is the investigation of choice for the patient with ulnar side wrist pain persisting after an acute injury. The fracture of the distal radius will be discussed in the next session tomorrow, inshallah. Thank you so much to all of you.